All right. Exciting times. Welcome, everybody. We have a very jam-packed agenda for you today. Just for a few housekeeping things. All of the information you're going to see today, including the video, including the PowerPoint, including some data articles that Dr. Pepe is going to show, all that's going to be available in our public folder that will have a QR code at the end of it. So you don't have to worry. All this will be available. You can R&D all of it. Just for some background, for those of you who are joining us for the first time, we started something called the Florida Whole Blood Coalition. The credit goes to, first and foremost, Dr. CJ Winkler and his team, Randy Schaefer out in San Antonio, who started this whole thing. And then Dr. Jim Roach, Chief Heath Clark, who we give great credit to because they're really the first folks in Florida to start this. And we just R&D'd everything from them. And then we said, hey, let's start this collaboration. And it's really blossomed. We have a lot of people on this call who are really the leaders in whole blood in the civilian population. And if you're here learning for the first time, welcome. And again, we have a great program in store for you today. We do have a mission, and I think that everyone is pretty much in it for the same reason. You're all here because you want to get the right people around the table. And as you'll hear from some of our speakers today, it's all about setting up the stakeholder groups early on. You're going to start a coalition, have a mission statement, be sure that you're doing it for the right reason. And you're going to hear today from Dr. Scott Branny from the state of Colorado, who's doing exactly that. And he's probably doing it better than we're doing it. And you'll hear from him shortly. Just incredible work is being done across this country. We're at the precipice of something very big here. And we'll all look back on this in 20 years and say, hey, we're part of this. So very exciting. We have an agenda here today. So we've been through the welcomes. Each person will introduce themselves as we kind of go along. But first and foremost, we're going to have a great talk by Dr. Pepe coming up here in a few minutes. And Paul, I'll give you the screen share in just a second. Yeah. But
keep going. I'm trying to put the talk together, so that'd be great.
Typical Eagle style, right?
Yeah, right.
There's a lot of questions out there on TXA, a lot of questions, and Dr. Pepe will really unravel all the data and make it clear why you really have to look at the data in a very specific way. Then moving on to calcium, there's a lot of questions about calcium, and Dr. Pepe will give us a nice overview and will attempt to kind of steer us in the right direction, which he oftentimes that's his niche, right? He steers the ship, and he always ends up at the right place. If Dr. Meg Marino or Chief Dransfield are from New Orleans EMS, I'll have them follow Dr. Pepe with their update, and you'll understand why I did that in a minute. And then we're going to go around the horn to lots of different places around this country doing some great things. We'll talk about data collection efforts in Tulane Registry. And if you're doing whole blood and you're not in the registry, we're going to hook you up with Danielle Tatum, Dr. Danielle Tatum, and Dr. Juan Duchesne. We're going to get an update from another visionary, Dr. Ken Shepke from the state level. And then Dr. John Kramer is going to talk to us about a really big thing he's starting at the federal level, which is just incredible to me. And then we're going to finish it off with, the person who started all of this, along with Randy, but Dr. CJ Winkler will join us. So without any further ado, I'm going to bring in Dr. Paul Pepe, who's been a mentor to me and many other people across this country in this field of EMS. So Dr. Pepe, can I have you share your screen if I...
Whenever I had to make a decision about what our protocol would be or what decision I would make in a particular patient on scene or whatever it may be, or in the emergency department, I'd always say, if this was my family member, if this is my daughter, if this was my brother, what would I do? And this is, you're going to see, this is what I would do as we get along here, particularly with respect to TXA. All right, let's roll. So as I call it, transition to tranexamic acid. And I was supposed to give this originally at the Eagles meeting, and we never had a chance to get it. But and I was going to come on as Dr. Reddy Whip there, so we'll see how it goes. All right. So disclosures, right? All the coffee beans in Columbia wouldn't make me a morning person. That's the only disclosure I have, and I'm non-essential as well, as everyone knows. We actually published on this with John Jew and John Holcomb a few years ago about non-mechanical hemostasis in trauma. And that included various things, not only giving blood, but also giving TXA as well. And we then later did an update on TXA and TBI. The bottom line here, and Jim Roach, who of course has been so instrumental down here in South Florida, getting things going here with blood, was on that with us. And bottom line was, it really is, it's nothing has changed in my mind since then, and no other data have come up to change what I'm about to tell you. Okay. So JSOM published the TCCC proposed change in 2022 for 2022 guidelines, where they said down the below the most significant updates to the guidelines are including significant traumatic brain injury as an indication for TXA, and I will mention that today. And although we're focusing on hemorrhaging patients and so on, this goes hand in hand with the hemorrhage guidelines as well. And the issue is to change the dosing as a single 2-gram IV or IO administration. And then we're recommending it, as a slow IV push. And we all have made different interpretations of what that is as we get along here. So this all got started with the CRASH 2 study many years ago, published back first in 2010. The thing that's interesting about this paper is that their protocol said that what they did was they randomized people within 8 hours of injury, and they had a loading dose of gram over 10 minutes and then 1 gram over 8 hours. This is going to be the key point. This all got started because people would give a loading dose when they were doing some cardiac surgeries or other types of surgeries back in the 60s. And then they would give this over the next period of time while they were still operating, et cetera. So the interesting thing is that that's what people have used to apply to trauma, which we, in retrospect, think was not a good. So when you hear about me talking about the 1+1, I'm talking about 1 gram up front and then 1 gram over the next hour, several hours. In this case, you see here that they also went out to 40 countries, and they actually found a difference. Now, the differences were very small in terms of the outcomes, but there was some positive difference. I'm about to tell you why they had some positive difference, because they gave it, just not to bury the headline, when they gave it very early on, that's where the better outcomes were showing up. And I'm going to show you that here right now. So overall, they said, hey, we had better outcomes here. As you see, for bleeding deaths, early TXA treatment is better. And on this side, this is better outcome versus worse outcomes on this part of the slide. And Peter, can everybody see this okay? Am I showing you the right?
Yeah, it looks perfect. Yep.
Okay, good. So this is the overall outcome. And that's the problem. People always take the bottom line, the yes or no line, without looking at the data and breaking it down. And so what happens is it turned out that if you actually, if you actually got treated within an hour, look at this, your chances of dying was 0.7, like 70%, 0.7 chance of dying over, let's say if it's a 1-to-1 ratio, you're saying your chance of dying is only 2/3 of that, of what it normally would be. And so that's what pushes, but that means this is a balance of something else. Okay. And that balance of something else was that over 3 hours, if it was given late, you had worse outcomes. Now, why would you have worse outcomes? And again, we're going to talk about that in just a second. Well, the worse outcomes is attributed to the fact that it's a thing that causes you to clot. And if you live long enough to have clotting associations, you'll have risk of problems. And this is what's interesting, is because at first, many of the surgeons had been not accepting it, whereas military people, where many our trauma surgeons weren't, because when they did the studies in the hospital, a person lived long enough, they actually had more, they started seeing these complications, all right? So, and that's totally understandable. And again, where I'm going to be going to is that if you give it early, and I mean really early, it's a good thing. There may be some complications, but you will have a better chance of living if you're in a position where you have to get this. It's that if time goes on and you give it later, then the risk-benefit ratio flips, where risk is now much higher, et cetera. And that's going to be my main theme here, but I'll go ahead and give you some of the data, all right? So again, let's go back to this. If you give it here within an hour, and that is what made a difference. So which way do we go? All right. The really cool thing is that we started understanding this, and right about that time, people like Dr. Marty Shriver, who did a study on head injury cases, following one also that was called Crash 3, by the way, which showed kind of similar results. It sort of kind of, yes, it was a little bit better, et cetera. But what really came down to when Marty did his study with the ROC, Resuscitation Outcomes Consortium, he prospectively asked, we're going to see what happens if you had a person with a head bleed. In other words, if you later document they have a head bleed, let's see how they did in terms of their survival, et cetera. All right. And that's Dr. Schreiber right there. So this study, published again in the JAMA, overall didn't show a real significant difference between it because they lumped everybody together. And one of the things I'll tell you is that they lumped the 1+1 grouping with a 2 grams right up front group. So everything was kind of mixed together in those two groups. You'll see why that becomes really important as we go along here. But when they did look at the specifics thing of this 2 grams versus 1.7 versus placebo, so they had the wisdom to look at this in terms of 3 arms. You lose a little statistical significance, but still 2 grams versus 1+1 versus placebo. And they looked at moderate to severe TBI cases, okay, in this particular situation. What was interesting is the median time, that means half the people got it within 40 minutes of the time of the injury. So that's pretty significant. And it goes along with the line of what I've been thinking, what the TCCC people have been thinking, that, my mantra has always been the earlier the intervention, the better results. And this was that's pretty good to get it in half the patients with that period of time. So, and the other thing is that nearly 60% of the people later were found to have an intracranial bleed. And then, of course, that meant there was 44% without, which, by the way, is a nice built-in safety cohort. In other words, they didn't have any bleeding in their head, and yet they got this and didn't hurt them. And just to jump ahead, it was perfectly safe to give it to them under these circumstances. They didn't have more complications or anything like that. So the overall results, again, were 65% plus versus 62% for the controls. But remember, the 65% thing lumps both the people with head injury, with head bleed, without head bleed, and also it lumped in the ones that got the 1+1. They just lumped them together in that primary thing. But when you examine those with CT confirmed intracranial bleed, the target group, from my point of view, right, there was a 16% mortality with the 2 grams up front. Okay, and look at this. When you looked at 27% with the 1+1 infusion versus 26%, so mortality rates were about the same for the placebo plus the 1+1 gram versus the 2 grams up front. And this really started pushing me even further to being aggressive about, let's saying, if it's going to be more than an hour, I may not even want to give it. And certainly I don't want to give an infusion over the next 8 hours. If this was my family member, this is how I feel at this point in time. There was a slight risk of more seizures, but you have seizures anyways. It's like, they had 13 seizures versus 8 seizures out of the 300 patients that were being examined. But there was no other increase in complications, and it was they did fine long term, and so it was deemed to be safe from that point of view as well. So let's go back to this. What it really tells us is that this thing is what we need to concentrate on, the less than 1 hour thing. Early treatment, less than 1 hour is much better. And avoid going here. And particularly, I'd like to avoid going anywhere out towards over an hour from my point of view, right? So now when you look back at Crash 3, okay, under that circumstance, same kind of stuff starts showing up, that your chances of dying, this is like 60%, there was 40% less. It was only 60% of what it normally would be. And especially if you got it done, this is treatment, within the first hour here, this is minutes to treatment. So they did have a relative risk ratio that was much better. The earlier you gave it, the better off you were. In the ROC study that I just talked about there, what was interesting, the early time, less than an hour to therapy with 2 grams, improves the outcomes pretty significantly. And so that's what you see down here. Now, this is a time in days. So we're talking about the hour thing is in here, but you can see this is extremely low when you get into this, first quarter hour, half hour period here, et cetera. It's all showing the same thing. This is the bolus only group, the 2 grams IV up front. And now here's your mortality rates out here with the placebo and the bolus maintenance group. All right. So When the STAMP trial came out with Frank Guyette and his group out there, same kind of stuff shows up. Favors a transaction. They gave 1 gram, and then they gave one at the arrival at the hospital, which generally there was within about an hour, by the way, they pointed out to me. And again, all this stuff started favoring the transexamined group here. And the same thing, if the time from injury is less than an hour, they did better. And then if the blood pressure is less than 70, obviously the people who are sicker, much better, etc. So better with higher dose, better with treatment within an hour, and especially if you presented with hypotension. So anyways, when the article that just came out about a week ago out of, you might ask, well, what did they find there? One of the interesting things about the patch trauma group, which came out of Australia primarily, I knew the results of this, by the way, about 8 or 9 months ago, because they consulted with me and talked to me about it because they were getting ready to write the paper up. And I said, before you tell me the results, I just want to know one thing. What was your protocol? And they said 1 gram IV followed by 1 gram infusion. I said, you're not going to find any difference, or it may even be worse for all I know. But and it depends. And it turns out only about 20% of their people got the drug within the first hour, by the way, in this study, let alone the fact that they did the protocol with a 1+1. There was not the 2 grams up front. And as predicted, it didn't show any difference of that kind of thing. So it was very, very interesting that it said, right now, I was able to predict what their outcome was going to be without them telling me, just based on that alone. So in summary for the TXA, and I hope I haven't gone over too long here, Peter, is that there are better outcomes, but only if given early as a 2 gram bolus, as far as I'm concerned. It's safe if it's given early. And also, it's likely good for all trauma, including internal bleeding and TBI cases. And then we can talk later about giving it for other bleeding cases, obstetrical, and so on. But that's the reason why most of our protocols down here in South Florida do go this route. I know you mentioned San Antonio, and there's so many others. That's the same way we've been doing it, the same approach here. And by the way, I haven't seen any particular issues coming out of this that have been a problem that we have to note. Someone will have to clue me in if there isn't anything else to be noted about here. So again, coming back to it, 2 grams IV IO administration. Some people have asked me, by the way, about giving IM. And one of the things that a lot of us worry about there is, I guess it's better than nothing if you're in a tough situation where you're, for example, I don't know, pinned in a tactical situation. But your blood flow may not be so good, so maybe it doesn't absorb as well. Those studies are actually kind of going on. They may already be published, and I don't have the data, but that's one thing. The other thing is that places like San Antonio actually will give it early on. Just it's a logistical thing, because as they're getting the blood up and ready to go, they want this on board as soon as possible. And we try not to mix the two. And I think that's pretty much what I want to say about that for now. And then Peter, can you just add in TXA for kids? Should we not give it to kids? Should we give it to kids? What's your protocol say?
You could probably guess that we do give it to kids. We treat them just the same as everybody else. Nothing magical happens when you turn 18. So yeah, we give 15 milligrams per kilogram. And there's lots of data on that. And actually, the data from the military demonstrates that TXA in children does have a positive impact, a reduced mortality. So just like with whole blood, please have a whole blood policy or protocol for children. And also, if you're using TXA, do not exclude the kids as well. So that's my 2 seconds on that.
So Peter, you have a protocol, I think, starting around age 5 or something like that. How about if it's a 3-year-old, and they're bleeding, and it's not good?
Yeah. So
accident on the beach, whatever, that kind of thing, right?
The protocol allows for whole blood in all ages. It's just that, and we're not a mother may I call the medical director type of people, but for this particular thing under the age of 5, it's just a call to the medical director. The dose is still in the app. And so, before launching this protocol, I looked at 5 years of data from our children's level 1 trauma center. And in 5 years, we didn't have one child who needed blood in the trauma bay under the age of 5, although there are stories from other places that do have that. So it's not that we exclude under age 5, it just requires a call just so we're aware of what's going on.
And that's for TXA as well, though? That's what I was asking.
No,
Huh?
no,
Okay.
no.
That I just wanted to ask that. All right. Does anybody have any questions of me? Do you want to?
Yeah, Paul, let's keep going only because we have a tight agenda. So if you want to do the calcium, then we'll ask
Yeah.
questions after you do the calcium.
Okay, good. I'm fine with that. I just want to make sure if anything wasn't clear here, let me know. Okay, so thanks. So in conclusion, I think we're going to get back more people than we did before. So how about giving that pre-hospital with transfusions? So what I'm going to do is, why would we do this in the first place? Two, should we use calcium chloride or gluconate, and what route should we use? You know, IV, IO, IM. Pros and cons on doing it pre-hospital versus in-hospital. And then some of the general questions that we won't address so much today, but just to know there are effects on the heart, phosphate levels, the microcirculation and various things that we have yet to explore. And there's even more things we're going to talk about in terms of trauma itself causing hypocalcemia. All right. So let's go to the why. So the why is that things like EDTA or citrate, which are calcium chelators, are used to stop the clotting of stored blood. If you absorb up calcium, you actually create a more of a a less coagulated environment. So these numbers might be wrong depending on what situation or what it is, but there's a certain amount of this stuff is added into it. So usually they'll give you 3 grams of citrate or 1.6 citrate plus some other calcium binder. And that's it. And then of course, if you have to then break it down further, like into RBCs, they might have to add, let's say 40 mils more. So that's 80. And if you're giving 2 packs of red cells, then you might be giving a lot of citrate. And it depends on the formulation. Like for example, if you're having one that lasts 30 days, you might have more. So those are all things that are right there. And in fact, Randy Schaefer, if I could make like a 10-second intro, isn't that sort of the case from what you found is different? There may be, depending on how long they want to store the blood for, there may be different dosing of these kinds of chelators.
Yeah, if it's CBD versus CPDA1, and the first one is usually a 21-day life cycle, and the second is a 35-day. I do not know enough about the difference, but I'd be curious to see if there is some. So I'm going to start looking that up.
I would just say that the main thing is be aware of this, by the way, and you might want to find out in your area, what they're using and how they're using it, et cetera. So just bottom line, though, it doesn't matter. It's lowering the calcium. And once you get to your bloodstream, it lowers it even further. All right. And then also there's free floating citrate in your bloodstream. So, and what happens if you're injured, like you have a damaged or poorly perfused liver where it's usually metabolized, the levels of citrates, for example, could go up, and then you have toxicity from it in the sense of really taking out more calcium, et cetera. So you got the general idea is that you are at risk for it. But the interesting thing is that you actually can get it from the trauma itself. Now, I'm not absolutely sure why this happens. My personal belief is that it's related to the fact that when you get into an acidotic state, you're producing a lot of H positive hydrogen ions. And so it competes with the calcium, may drive it down. And so as a result, you may have, there may be other reasons that I haven't delved into yet. I'm just learning more and more about this. But even so, without giving the blood, you can find that you're hypocalcemic in some of the cases that we're talking about here who are at risk. So a concern. So more and more, I've been thinking this is what we need to do. But what's the treatment? Should you give calcium chloride or calcium gluconate? Well, it turns out that in theory, anyways, calcium chloride might be better because you get better free calcium ions out there right away. Or is that a problem, actually, because you affect other things? Because once you put calcium out there, you will affect potassium levels, you'll affect all sorts of other things as well. But probably in this case, because you're so hypoglycemic, de facto, whether you've had blood or not, is probably, it says that takes some of that worry out. But there also is a risk for sclerosis, meaning that if you get it into like a peripheral IV site and it extravasates, leaks out, you could cause really bad sclerosis in that area. And then, Peter, you have a case in which it was an injury to the leg, but they just did they give it into a vein in the leg, or how happened? But I heard that there was cases where At some hospitals, they had to amputate a kid's leg when they gave this, and so as a result, they've switched over to calcium gluconate altogether. Is that right?
Yes, that was a pediatric patient, and the child did indeed require an amputation. So they just
Was it
took
a
off.
leg or an arm? I'm sorry, I didn't know about the amputation. I'm sorry that I didn't know that. I was just thinking badly leg, but it probably was arm, right? Where they probably
No,
gave.
it was a leg.
Oh, and they were they gave the IV or whatever through the leg, or did
I'm
it?
not sure if it was a central line or an IO, but it was
Yeah.
it was right lower extremity.
Right. Anyways, but theoretically, if you get a good IO in, by the way, it's fine to give it that way. There's not a problem with this, And then of course we have emphasizing femorals and humorals maybe in adults. But here's the problem: did you get it in? Did you get it in the right place? Will it cause a problem like we've seen here that we're not sure about? So there's a lot of questions out there about this. Okay. So bottom line is that when you look at the joint trauma system, recommendations anybody can look up. Here's their quick reference guide, and I'll pull it up a little tighter. It says to prevent hypocalcemia related to massive transfusion, monitor ionized calcium, administer it early, etc. But just jumping down here, it says that calcium gluconate is preferred for peripheral IV administration. In other words, that you really have to have a good central IV in if you're going to give it calcium chloride. So you may be saying that may be the way to go, and it may be the preferred way to go under these circumstances. Okay. All right. So now what's the pros and cons of pre-hospital? So most of us have thought, hey, let's just get it when we get to the hospital because we're only given a unit out there. But when you consider the fact that maybe you're just getting hypocalcemia from the trauma itself in these patients, maybe that gives you some pause and think maybe immediate treatment is good after all, versus the hospital arrival where you can get a central line in and all those kinds of things. But one of some people would cite, and I don't know if David Miramontes or CJ could comment this, is that part of it is also you need an extra IV. So it's the logistics and maybe it's the time issue, and let's just do it later on or go in hospital. And then in the hospital, you'll have the ability to check for calcium, phosphate levels, potassium levels, and all that. And someone would say, by the way, there's no proof that gives you a better chance of living. They give it pre-hospital. I think there is enough data, and we're going to send you some papers to say your chances, if you let the calcium go, if the persons there have hypoglycemia, it's associated with death. So presumably treating it would be a good thing. But so giving it pre-hospital, does it make a difference? We're not sure yet. But I'll tell you what, as I've learned more and more about this over the last few days, and I'm going to learn more and more, I'm leaning more and more towards giving it in that pre-hospital setting if it doesn't delay things, and using gluconate so we avoid all the other hassles that we were just talking about with the calcium chloride. So in conclusion, the answer is do give it pre-hospital or don't give it pre-hospital. And that's everything today. If you're giving it, like Eric Bank, I think, is on the phone, that you guys have been giving it for IV calcium chloride for years. So the bottom line is that you could give it, and I wouldn't have a problem with it, and if you wait till the hospital right now, I don't have a problem with it. Although I will admit, when we talk about which way do we go, I'm starting to lean more and more pre-hospital, as I always have. So, and then with that, on the road to the 22nd century, I hope we'll make life better for future generations. And I'll take questions now. How's that, Peter?
Awesome. That was a great presentation. Thanks for summarizing the data, which
Stop sharing. Okay.
Oftentimes this data gets confused by people who are just reading it on Twitter. So let's bring in Chief Eric Bank. Chief, Dr. Pepe called you out on that. What are your thoughts, and how's it been going for you in Houston area?
Yeah, so we haven't had any problems. So we usually do it. We do the 2 gram TXA up front, flush it, run the blood products in, and then after the first unit of whole blood, they get an amp of calcium or a gram of calcium. And we haven't seen any cardiac effects, any ill effects. Obviously we do kind of emphasize that it needs to be a good flowing IV or IO, but again, we're giving blood first, so we're going to know that IV is functional before we get to the calcium. And we just stick with.
Yeah,
sorry,
and you don't. No, it's okay. And I just want to make sure, as you're on that point, is that we don't mix the blood with the calcium. Okay, correct. So I just want to make
absolutely.
sure. Yeah, people know. So, so the point, and then you do give calcium chloride. Is that right? I want to make sure I emphasize that. Correct.
Correct, because that's what we already carry. So instead of carrying 2 different medications, so if we do actually switch to gluconate, we'll just switch completely over. But right now, we're still carrying calcium chloride.
Okay, good. Thanks very much.
So Paul, let me bring in Chief Tom Dransfield from New Orleans. So Chief, are you there? Because I know that during Paul's talk, Dr. Pepe's talk, he mentioned that if you use packed red cells, then you should give calcium. And you in New Orleans are using packed red cells. Can you comment on what you do and how it's going there?
Yeah, it's we've been using it ever since the inception of it, and we do of course, the PRBCs. They're 300 mils versus the 5, so we have the same standard loadout that everybody else was talking about. We give the blood, and then the calcium, and then the TXA is basically the batting order we give our guys to do it in. We prefer a second line or a second route or access for the TXA and the calcium, so the blood is dedicated. A lot of times it's not. That's all we can get is one access through the IO, so they flushing it with at least about 20 mils is what we recommend in between the blood and the TXA, or the calcium and TXA, so we can get that out of the way. But we haven't had any reports. Dr. Tatum's on the call. She's with the university. She might be able to shed some light, but we haven't had any feedback about any ill effects or anything from our calcium administration. And we use the calcium chloride as well, just like Eric was saying, just because we already had it and we were keeping it simple.
Thanks, Chief. So, Dr. Tatum, he called you out there. I have you later in the agenda as part of the 2-lane registry, and thank you so much for that. Do you have any comments on what the Chief was saying?
No, I'll just apologize in advance for not being Juan. Sorry, he's
okay. No,
in the air on his way to Puerto Rico, I think. No, Tom's exactly right. I was actually, I was lecturing before, so I was a little late and I didn't see Tom was on. I'm glad he's here because he's the authority. No, we haven't seen anything. And New Orleans has been giving this as a bundle. So it's our resuscitative, advanced resuscitative care bundle. So like you said, it's the 2 grams TXA, 2 grams calcium, and most patients are getting 2 units of packed cells in the field combined with the short transport time. So our results look pretty nice if you're just looking at mortality. Sample size wise, from statistical standpoints, we could use a little bit more power to sort of look at, any complications or anything like that. But so far, there's been nothing to indicate that this 2 grams of calcium in the field is causing any adverse effects. If anything, it might be more protective. And sometimes I wonder, I was like, are we giving enough calcium? How do we know how hypocalcemic these patients are from the trauma itself and then from the chelation of the citrate in the product? So we're actually looking to compare some of these things in some upcoming studies, but I don't want to spoil my whole spiel for later.
Yeah. Hey, by the way, do you do any red tops, like collect a sample of the blood before you come in or give your blood, or maybe that's something that many of us could consider if it's possible or feasible? That's a thought.
No, we don't do that because back in the old days, when I've been a medic forever, we used to draw blood for the hospital and everything. But they just traditionally don't take it. They don't think it's clean. They don't want it. They just would throw it away. So we don't do that anymore.
Although we could make it part of a protocol going forward. But let me ask you this, Danielle, while I got you there, as our, our representative surgeon here, the issue of hypocalcemia pre-blood, in other words, getting from just trauma alone. What is your understanding of the mechanism, or do you have as poor understanding as I do? Right.
Yeah, I think we're in our early days in that, right? And so one of the things I think we're kind of lacking is really understanding how hypocalcemic these patients are. We're saying hypocalcemic, but it's a continuous variable, right? It's not dichotomous. It's not yes, no. What are you chasing? And I think that's a question we should start trying to answer. Measuring ionized calcium is real hit or miss here. And sometimes it comes after the transfusion's already started. So if you compare it to patients before they got blood, then what are you really looking at? You've got apples and Volkswagens. And so it's not a good comparison. So I think that would be a great thing to look at in terms of, and can we do that in the field? Can we get point of care type calcium assessments up front to know what kind of, rabbit we're chasing here?
Well, before let's get me off the stage, but I do want to say, does anybody have a dissenting viewpoint from dissenting viewpoint from what I put out there today, or having disagreement with it? Because I like to know that and try to have an open mind about what I put out to everybody there.
And if somebody does have a comment, or you want to just put it into the chat, you can always contact me afterwards, and I'll make sure Dr. Pepe gets the message. But Paul, that was phenomenal. And clearly there's a lot of discussion around this topic. As usual, you're ahead of the curve on it. And we appreciate you kind of trying to point us in the right direction. And with Dr. Tatum and many of the others who are, either doing or not doing calcium. I think with the Tulane registry involved, we'll be able to get an answer on this hopefully in the coming year. So thank you so much, Dr. Pepe.
Yeah, thanks for putting up. Hey, do we have CME on this thing, or is it without?
You know what? Not today, unfortunately. I apologize for that. It's my fault.
Okay, we can work on that for the future, but that's it. Hey, Randy, can you let's have, by the way, Randy, why don't you pipe in? I forgot. Dr. Jenkins is doing a study on this. Tell us a little bit about that.
Yeah. So after we talked yesterday, it started generating the wheels. There's some random military publications that are put out that it's really hard for you all to find online.
Right.
I forgot I had one of them. So there is currently, the study is called Calcium, and it stands for Clinical Assessment of Low Calcium in Trauma. So it's a 3-site study with Brooke Army Medical Center, University Hospital, and up in Colorado at the trauma center up there. And they're going to look at, indeed, all the things we talked about with the impact of calcium on trauma.
Okay.
They're going to measure it at, they're not doing it pre-hospital. In this case, it'll be arrival, 3 hours, 6 hours, 12 hours, 18 hours, and 24 hours after trauma.
All right.
Oh, wow. Okay, very good.
Is it going to be St. Anthony's in Denver, I assume?
I haven't read that far yet, but
Okay.
I connected you an email with Don Jenkins. He already wrote to you while we were talking.
Oh, no kidding. Okay, I'll give him a shout. All right, listen, I better get off, Peter. This has been kind enough to give me all this time. I appreciate it. So
Perfect timing. Thank you so much, Dr. Pepe, for that. I'm getting some messages. If we can get a copy of the presentation at the end, we're going to give you a QR code. You'll get everything. So don't have to take pictures of your screen. All righty. Moving onward. We are now going to go around the horn. We have a lot of great people on this call, people who are spearheading things at their departments. But I really want to bring in first is Dr. Jim Roach and Chief Heath Clark, who I give the credit for, years ago, they said, we're doing whole blood, and they did it. Broward Sheriff's Office, very large EMS system here in South Florida. And so Dr. Roach and Chief Clark, would you mind coming up on the stage and giving us an update of what's going on in your neck of the woods?
I made it back just in time, I guess. Can you guys hear me?
Yeah, we hear you.
I don't know if Jim can make it on. His schedule lately has been kind of crazy.
Yeah.
We added TXA earlier into the year. We kind of slowly rolled that back out. We started with blood first, which I realize is probably backwards compared to most people's experiences. Update of numbers right now. We're at 116 applications of whole blood products, and our 24-hour survival rate for that is 73%. Working with our hospital partners right now to start collecting the data for the 30, 60, 90-day outcomes. We'll be talking to Jim about how we're going to pursue documentation and studies and so on and so forth. I know Dr. Pepe will be involved with that. Dr. Levy will probably be involved with that. We're going to try to utilize as many resources as we can. But I mean, all in all, if any of you are new to this, I can tell you wholeheartedly that this is an incredible project. I highly recommend that anybody that's not pursuing it, if you don't have it in your region, that you try to put it in your region. And I can tell you that I miss more cases than I actually deliver on due to staffing issues. Half of my product is kept on a helicopter. Obviously, it rains a lot down here in South Florida, so we have weather limitations. We also, because of the nature of helicopters being what they are, we have mechanical limitations at times. So that sometimes reduces my level ability to access my patients. And then I have one terrestrial-based EMS officer that also carries whole blood. The issue there is it's 400 square miles and it's a regional unit. So can't always necessarily get to where they need to be, unfortunately. But even with that, it's almost 120 some odd cases, had a significant impact on many, many people's lives. And I think we've at least anecdotally proven that this is worth reinvesting in and expanding. I think the powers that be within my agency and within the county are starting to take notice of what we're doing. I have a local news piece starting on Friday. I'll be getting interviews, so that should be interesting. Haven't done that in a long time. Hopefully this one goes better than the last one did. But it's starting to gain traction down here. And I think that when we speak about it, enough people, and a lot of credit, of course, goes to Dr. Roach, Dr. Antevi. There's been a lot of people that have actually been carrying this torch and trying to make people pay attention to what we're doing. And like I said, it's a very special thing. And despite my logistical issues and whatnot, we've had a dynamic impact. So if your system's a little more compact, because I can tell you that one of my issues is we're not one sole entity. We're not just a city. As the county agency, we contract throughout the county with multiple different entities, and there's often very big coverage gaps with municipality fire departments between us, who we work with very well, but it can slow things down when it comes to actually providing coverage. So if you're working off of one concise, we'll say Fort Lauderdale, Florida, they're right next door to me. They're a big department. They would probably be very successful based off the fact that everything they do is kind of centered in one area. So I know a lot of people look at the initial expense or the commitment of manpower or personnel, however you want to look at it, as being cost prohibitive. I would caution them to look at what it actually costs to actually run the program and really look at it when you extrapolate it out. I mean, if we're looking at maybe $1,000 of application whole blood, that's cheaper than running a code. And we do that with our eyes closed. And quite honestly, anecdotally, the blood seems to be more effective. So if I can do this and I can be successful with my unique operating situation, city departments absolutely can. So I am a big proponent of it. I'm not always as readily available as I would like to be for questions, but I think we can get my contact information out there. And if there's anything I can do to provide any further information to anybody on what we're doing, what we have found that has worked, what hasn't worked, what we would like to do, I'd be more than happy to share it with anyone.
Well, Chief, you've done so much, and I know that you're busy, but you've done some great work, and we really appreciate you and Dr. Roach. We are going to rope you into a potential concept of education for the state of Florida, similar to what San Antonio is doing. So stay tuned for that. Speaking of state of Florida, let me bring in Chief Charlie Coyle, who is incredible, our EMS chief at Palm Beach County Fire Rescue. And I've asked Charlie to really talk about our update at Palm Beach County, but I also wanted him to get a little tactical because he's so good at putting together a process and then evaluating the process in an ongoing fashion, and sometimes in a day-to-day fashion. He's incredible. So Chief Coyle, please join us up on the stage and give us the update.
Hey, Dr. Antevi, thank you so much. And thank you for putting up the slides. Much like Peter Antevi fashion, I found out about 15 minutes before the talk today what I was supposed to talk about. So any good Peter Antevi talk is done in the parking lot before you walk in. So one of the things Dr. Antevi asked me to talk about today specifically was, Palm Beach County Fire Rescue, we cover a lot of ground. So we're 1,800 square miles. We have 50 fire stations, and daily I have 9 EMS captains that work as an EMS supervisor. So the question that he had for me was, how do we figure out where the blood was going to go? So when we first started up our program, we have 2 helicopters. We have 9 EMS captains. Where do you put the blood? So a couple of the things that we looked at specifically were our battalions, which is on this map that shows the H's on it, where the hospitals are. We have 2 level 1 trauma centers, and then we have it broken down by battalion. So specifically what we wanted to look at is we wanted to see traumatic cases, and then we used the criteria for the protocol, and then we just used a heat map, a GIS map, and then we just plopped the dots down on the map. So what we decided was we were going to start with a formula saying that, number one, how many patients were in that little area where these battalions respond. And then number 2 is, what is the proximity of the trauma center? So we started out at 1 battalion. The picture on the right over there is just basically kind of granular to one particular response zone. And, we started with 1 EMS captain, and then we started with both of our helicopters. So, and then, he asked me, he says, well, what do you do now? How do you expand the program? So Doc, if you could change it to slide 2. And basically, this is something that we run monthly now. And this is just basically looking at our electronic patient care reporting. And we use crystal mining, our crystal reports, which is a data mining tool that is very specific, but not as specific as you would like. So essentially, we look at our trauma cases. We use our protocol for whole blood, and then we extract out every case. But we also look at the incident number, because you have to double check the case. We look at the call type, and it's very important to understand the dispatch as, because we need to make sure that we're putting the EMS supervisor at the actual scene, because only the EMS supervisor carries the blood. And then we adjust our dispatch protocols over time. But what this allows us to do is we take this and then we put it on a map. And then as we go to expand our program outwards, then we understand completely what should be the next area of movement that we're going to decide to, implement whole blood and put it on our EMS captain's supervisor's vehicle. And then the last slide is just, basically we had our 1-year anniversary. And I will tell you that this is not done in a silo. I know Dr. Winkler is going to be on the call if he's not already. Dr. Peel, Dr. Holcomb, Dr. Roach, Dr. Antevi, Dr. Shepke, Heath Clark. We have so many people to thank because ultimately you provided us, a roadmap on how to do this. And basically we had 56 patients total for our first year of operations. This slide here, although appears to be busy, we took all the arrest cases out of this. So we were left with 35 patients. And out of the 35 patients that did not go into any form of traumatic arrest, we've been able to see an 89% survivability. And then if you look, 76% of those patients had a decrease in their shock index. And I could go on and on and on, but I know that our time is very limited today. So again, the mapping, the crystal reports, how we got to where we were going to put our blood. We are up to, I think, 4 EMS supervisors now. So the way our county's laid out of the 9 EMS captains, 4 of them have whole blood. I believe next month we'll be launching it in another battalion, and we will continue to make data-driven decisions here at Palm Beach County Fire Rescue. So again, thank you for the time, and thank you for all of the people that blazed the trail for us to follow.
Chief Coyle, incredible update, and that tactical kind of overview is very important. And if anyone else out there is doing something similar, please let us know. I would love to have you on further on the future webinars, because I think that type of information is also just as important of how to get a program started. Let's move on. Yeah.
Peter, I want to ask Chief Coyle a question. Is that okay?
Yeah, go ahead. Yeah.
Yeah. So, hey, Chief Coyle, fantastic presentation, by the way, as usual. So, but I just want to point out on the issue where you had the traumatic arrest is that one of the things we found early on was that if they were pulseless on our arrival, their chances of surviving were basically pretty nil. And we're going to look at that and see if that's, that going to be the case, and you can have better utilization as a result. But the other interesting thing is you saw that that in the other patients who were pretty sick to get this stuff, the way the protocol is now, I even think it should be liberalized, is that they were pretty sick. And then you showed these improvements, and the outcomes were really a lot better than they have been historically. But one of the things I think is that people should use is that shock index that you pointed out. I wanted to do that. And I think your numbers would even be higher. I don't know, did you delineate the people who were crashing, for example, if they had a pulse of 70 along with a blood pressure of 70, right? Because they were crashing. That's a initial shock index of 1, and I've seen where you fix those people, by the way. So that's something to be looked at when you look at the shock index, because your data may be even stronger than you think. That's that commentary. Any reaction to that?
Yeah, so essentially, if you look, it's kind of odd because in 4% of the patients, the shock index actually went up, not down. And that's because they were so bradycardic when we got there. So exactly what you're saying, Dr. Pepe, of course, we can't pull any of the tricks on the data with you. But that's exactly what you said is exactly true. So a couple patients were extremely bradycardic. They got the blood, their heart rate increased, and their blood pressure did stabilize as well. But it looks like the shock index went the wrong way. And essentially, it actually was just bringing the patient back to life. And the shock index was a poor indicator of that.
Fantastic. That's why I wanted to bring that out, And then the other thing I was going to say is one of the things I'd love to see you do in the future, we'll talk about that later offline, is looking at the time from the incident to the time you gave the blood. Is that a factor? There's so many other factors, though. It would have to be probably in a regression analysis. But I think that's a good thing, because I hear people saying, well, we're so close to the hospital, we'll just get the blood at the hospital. And I think every minute counts out there with the type of patients you've been treating. Okay. That's it.
Great discussion. Appreciate that. That's fascinating. The bradycardia and the shock index. I love that discussion. All right, moving on. So I'm now going to bring in someone who took on an entire region by himself. I'm saying by himself, but obviously he's great at building teams. But we're going to move now to David Long from the Tidewater EMS region in Virginia. So David, tell us how things are going, and please give us an update.
So if you can see my screenshot, you'll notice that there's an interesting background. So I just happened to be on vacation in Kona, Hawaii. So aloha. That said, I guess what I tell you about the Tidewater EMS, program at this point is that we're 10 months in. So we are 29 cases thus far. So 18 of the 11 have, or 18 of the 29 have survived discharge. So that puts it about a 62%. I think for a 24-hour survival rate, like Chief Coyle mentioned, we're all right around that 73%. So it is interesting that when you look at these different programs from Broward County down to Palm Beach County, for us, a lot of the numbers, within whether it's 2 percentage points and et cetera, seem to be tracking, almost the same. So we were able to successfully expand into the city of Chesapeake. So we have city of Portsmouth and the city of Suffolk here on our horizon. We'll be moving to pediatric administration in September, and we'll be using the 5 years of age to 12, along with the popular HandTevi app to get that done. And then we are in the process of doing an IRB on the calcium issue. We believe, from data that we've culled in region, that none of our healthcare systems essentially administer calcium chloride unless it's through a central line. So when we started looking at some of the safety and efficacy, related to, treating our patients, particularly in the pre-hospital environment, we understand the potential risk that we take, administering calcium chloride. So I think our program will actually, stick to the calcium gluconate when we implement that, and we're expecting to do that, I think, the first part of 2024. And on the TXA is kind of a question for Dr. Pepe, but one of the concepts they're currently discussing is essentially the rollout of. So we use a regional, what I would call kind of a community drug box system that's supported by the healthcare systems here in region. And we've been talking about putting TXA in all of those drug boxes because we can't put blood everywhere. And if it turns out that, based on, assessments that TXA would be appropriate for administration, knowing that you may or may not get whole blood, would that be a favorable use of TXA versus, not carrying it?
Oh, you want to take that?
So the question is that if you weren't able to give the blood, but it's at a patient where you think they're bleeding to death, should we give it? And the answer is yes. It's just like if we were talking about giving it for the OB patient that we didn't have blood for, or the, whatever else it may be, the head injured patient, for example, right? So, sure. But again, I'm almost adamant about it. It's got to be done within that first half an hour to 40 minutes, if not an hour, or else then I think that it starts reversing. Others may disagree with me, but I'm just trying to emphasize that the earlier, the better. Then after that, it's up to you're right. People will be right to say it may be harmful at that point in time. Okay.
Sure.
Is that it? No, does that answer your question though?
It does, absolutely. So I think it fosters our position, that's likely the direction that we will head, and that would likely be as first part of 2024 as well. I think the other caveat is that we've been approached by a regional Jehovah's Witness community, and they're aware of the TXA kind of as an alternative to blood products. So they're pushing hard on us to provide that as an alternative for them.
Interesting. Okay.
Good. All right, David, thank you so much. Please
Absolutely.
Go back and enjoy your vacation. Your wife is probably like, where did you go, buddy? So you may need to blood yourself in a minute. But
hey, first of all, I have an important question. What time is it right there, David?
It's just before 8:00.
That's what I thought. Thanks for getting us.
Okay. All right. So maybe he's having a Bloody Mary. All right. All right. All right. Awesome. David, thank you so much. Next is someone that I've never met in real life, but I can't wait to, because what he's doing is something pretty incredible. We got a bit of an update yesterday from Stein Bronski, but I'm going to bring in Dr. Scott Browning from Colorado, an ED doc out in Colorado, who is putting together a coalition statewide in a very robust fashion. It seems just like a very beautifully done thing. So Dr. Browning, thank you for joining us today. If you want to join us and give us the update from the great state of Colorado?
I would be happy to. And again, I am just a small piece of this machine we've got going here. I know you got a chance to hear from Dr. Bronsky. What Dr. Bronsky and Dr. Angelides have been doing in Colorado Springs is outstanding. As I'm certain many people on this call are thinking, I'm also one of those people. I blame this completely on CJ Winkler. I was innocent until then. But having attended with a number of members of the Colorado region, the Colorado Whole Blood Academy, in March, we kind of came away and started kind of grinding some numbers and decided that as long as we were going to go through this degree of pain, it probably made more sense just to try and do the whole thing at once. Colorado represents a geographic region that's about 4 times the size of STRAC. There are some similarities. We're about 40 to 50% of our counties within the state are either rural or frontier. We've got about 5.8 million people. They're jammed into a 200 mile by 60 mile strip, pretty much jammed up against the eastern kind of front range of the Rockies. So we have some geographic similarities, but then we get to throw the Rockies and winter weather in on top of it as a modifier, even for what you guys get to experience in South Florida. I don't get to worry about hurricanes though, so I'm proud of that part. And so what we have been doing, we are still at an assembly stage from this standpoint. Our timeline, to be honest, is probably first pilot blood out in the field by somewhere between November and January 1. Dr. Bronsky and Dr. Angelides will probably have it at the earliest opportunity in Colorado Springs, very much in an urban setting like has kind of been already established by San Antonio Fire and a number of your guys' fire agencies in Florida. My focus on this is I'm a medical director kind of from the foothills going west of Denver all the way up to the Continental Divide. So I'm a little more focused on that piece of how we do an integrated program that covers our mountainous terrain. With that, I will right up front, this is a cold-blooded absolute ripoff of San Antonio. Without them, we'd be about 5 years behind where we are right now, but they were gracious enough with what they've shared that we've got a pretty good head start. And what we did is we have regional trauma area councils within the state, about 11 of them. We broke the state down where our groups to decide how best to implement this regionally are largely based on those 11 units. Some of them are very urban, some of them are extraordinarily rural. And so with this, we're going to have a very different model, I think, in terms of the application regionally within the state. But the goal is basically both to maximize our helicopter coverage, much as other people have done and San Antonio has done, to try and provide a little equity in terms of the ability to deliver this product to our more rural clients. And then obviously take advantage of what's already been established in terms of an urban model. We are fortunate to have pretty good buy-in from the state. The two biggest, I don't know advantages, but at least the things that move the easiest for us is that one, Vitalant, our blood supplier, does 96% of the blood for the state. So the blood supply process, I think, has been easier for us than it might be for some other parties. And then the other is that at a state level, our scope of practice group that basically advises on that had enough foresight last year to start piecing together a set of guidelines for when waivers were applied for, that those guidelines would already be in place. So it has made the application process for scope of practice waivers very easy from our standpoint within the state. Those two pieces are going well. The flip side of that is I've got 250 agencies and 88 trauma centers from level 1 to level 4, 6 level 1s, almost another 18 level 2s. We're pretty dense hospital-wise in some areas and then incredibly sparse in others where we've just got critical access hospitals. So trying to piece together a coalition of all parties, and again, I'm just a little piece of that, but brings together a lot of expertise from people both rurally. We have a lot of good legislative people. We've got a lot of good blood banking people. We've got some great level 1 trauma surgeons and centers to assist with it. So that's moving in the right direction, but we are very early in our timeline as we start building this. Our timeline, basically blood collection should be going by later this fall. starting to stock our hospitals again with the intent that pilot programs would be up and running by about January 1. The only kicker I will also throw out for you guys, just probably a discussion for another point in the future. Given our geographic problems and our weather issues, we've had some areas in the Rockies where we had 40% no fly days this winter, just because of a northern storm track and a lot of wind and snow. So we have put in a walking blood bank piece as an alternative for some of our retax to use right from the very start. I love the thumbs up. Not everybody gives me that thumbs up when I mention this topic. 2 thumbs up, like it even better. And so to be honest, it's very similar to, and this again, straight off the San Antonio model. I know there it's more of an MCI and backup plan. We still see it largely as that. We don't see it as the front running piece. But if we've got somebody who needs whole blood and I can't move it on the ground, or I've got a blizzard and it's going to take too long to move on the ground, it would be nice to have an alternative for those patients in the field. And that's kind of where we're going with that part. That's about it. Have had some initial discussions, at least as far as Tulane, as far as participating there. We have the luxury of, since we are starting a program, we can also start our data collection right from the get-go. And again, in a very parasite fashion, we are just trying to take the best of what everybody else has largely established and see what we can add to it. So the scope is a little bit broad, but it's the same tools and concepts that everybody else has developed and graciously offered up to us as things have gone along. So I'd love to say I have something original, but not very much.
Well, I could tell you that it takes a different type of brain to organize on this level, and you have experience with it. You're doing it in a very organized manner, and we're definitely going to be watching how things progress and learning from you, I'm sure, as things go along. So, any questions or thoughts for Dr. Brandy?
I'll just say real quick, if there's anything I can clarify for you, Dr. Brandy, on the code book that I sent you for the variables for the Tulane registry, let me know. But you
There
guys,
will be.
yeah, whether or not you guys participate, you have a really great opportunity with your rural times. That's something we're interested in. A lot of us are urban centers and our transport times are really, really short. But I have a lot of interest in also looking in the rural arena, because I think we're going to be seeing major impacts there. Patients with these prolonged transport times, when you're evacuating someone out of the mountain range, it's obviously different than 2 miles down the interstate. So yeah. I think as we get these diverse groups, we'll be able to answer a lot of really interesting questions and not just fitting this one type of urban EMS system.
Yeah. And probably an opportunity to speak as far as Dr. Pepe's earlier discussions. We actually, for the first time this year within Colorado, also put in place, we've had the Denver Metro protocols, largely derived by a set of Denver Metro physicians, have been our guiding medical direction documents for years. And this is the first year we've actually added in a prolonged transport set, with the anticipation that, you're looking to 20 or 30 minutes of transport versus, you can stand in downtown Denver and hit 3 different level 1s with a rock if you have a good arm. But with that, as we started to look at it, we included both upfront front-loaded TXA as well as calcium for our prolonged transport. So on that kind of marginal, it's kind of dancing on that same question you brought up earlier. How many of our trauma patients are hypocalcemic, regardless of their transfusion status? We think from that standpoint, calcium is probably going to be something that comes up to be demonstrated to be beneficial, especially if it's a long transport, regardless of their transfusion state.
Right.
Perfect. Scott, I want to say one thing is that, talking to people like Dr. Johannickman, they give you guys all the credit for getting this going. They said it was all the EMS guys that really made it happen. So I just want to say thank you, besides the fact that you were able to, and there's some pros and cons of what you're doing, but it sounds like overall the pros are going to outdo the cons as you do it on a statewide basis. So it's really great job. Fantastic.
Great comment. Thank you, Paul. Thank you, Dr. Brandy, for that update, and we look forward to future updates. All right, I'm going to move this program along because we have only 22 minutes left. Next up is going to be Lieutenant Colonel Randy Schaefer, as well as Chief Eric Bank. I know that for those of you who don't know, and she'll make an introduction in a minute, but Randy has done incredible work helping entities, small entities, large entities, states, get up and running with their whole blood program. I think that she's going to be the resource for all of us moving forward. So if you're interested in starting a blood program, or you have no idea what to do next, she's the person to talk to. So Randy, would you mind coming up on the stage and giving us an update? And then Chief Eric Bank as well can follow you. Thank you both.
Absolutely. And my first comment, walking blood banks are a bridging measure when your supply line is disrupted. And if you've ever been through a haboob in the middle of the Iraq desert where it's raining sand for days, that's a great indication when you can't get blood to you. So a couple of great, exciting things happening. So California is a state that does not have a lot of ground blood available. There's one agency out there, and it's actually on the military installation at Hunter Liggett. They had a great case recently where a patient was off the cliff and they had to do a very technical, complicated rescue and took the blood down the cliff to reach the patient. So we're hoping that we can get some more agencies running in California. I had the recent opportunity to catch up with John Pettini in Connecticut. If y'all don't know, he's got 2 agencies up there that have been using whole blood, and they're getting ready to expand to a 3rd agency. What's interesting is I like sharing best practices, but I also like sharing some of the challenges I hear about. The way the state protocol was written in Connecticut is they can only administer low titer O negative whole blood. So that's posing some challenges for them. They do carry 1 unit of negative and 1 unit of positive, but he is actively working with the state protocols to get that changed. So that's just a quick update. I'm working with Eric on a project where we're attempting to get all of the ground agencies mapped out in the country. I think we're over 90 now, and we're going to collect that data and submit it for publication. So if you're a ground agency and you're carrying blood or want to carry blood, if you could shoot Eric or I an email, I just want to validate the information we've got on our spreadsheet as we get closer to mapping it out for publication. And John Cromer is going to talk about this great national effort that's going on. So in the interest of time, I hand it over to Eric.
Thanks, Randy. Go ahead, Eric.
Yeah, Randy, so we're
email in chat, please.
Yeah, I'll drop mine in there too. So Randy and I are working on this project. So even if we know you, just please send us whether you're carrying blood products or not, what you're carrying, so we can make sure that we have everything correct. So we started down this road in 2016 with component therapy and switched over to whole blood in late 2017. So just putting some numbers together after talking to Dr. Antevi the other day. Looking at 2018 to 2022, because we've got a mix there in 2017, we've delivered 139 units. Our average age is a little older, 58 years old. And one of the most interesting things for us is that 103 of those patients have been medicine patients. We put a medicine protocol in initially because we thought we'd look really silly if we did this for trauma patients, and it's like a 3-to-1 ratio. 97-year-old is our oldest, 3-year-old was our youngest, 86 males and 49 females. We're at about an 82% survival rate. And the program continues to grow. Watching this grow across the country has been pretty amazing. Everybody's thanking CJ. CJ's great. San Antonio program's great, but I got to thank Dr. John Holcomb. I don't think he's on the call today, but we probably would not be here where we're at today if Dr. Holcomb hadn't helped me out in 2015 as we were looking to do this. And the time factor has come up a few different times. I know the New Orleans guys are doing this really close to the hospital. We're not in a Colorado mountainous area, but I'm 45 minutes from the closest trauma center. And we're on the west side suburb of the city of Houston. So we don't have 3 trauma centers. We have 2 that you can hit a 9-iron between the 2 of them. Dr. Pepe's pretty familiar with that. So again, happy to help. Our emails are in the chat, and please email us if you're working on a program or you have a program in process.
Awesome, Chief Bank and Lieutenant Colonel Randy Schaefer. Thank you guys for doing that. And I think mapping out where this is going, obviously started with you, Eric, and now it's expanded across the country. So I think that bit of history is good for people to understand. And the resources that you guys are providing and your time and your availability has been incredible. And all the people on this call who have not started yet, we're trying to provide the resources to people because we want to help you. That's why we're doing these things today. All right. I'm going to be moving on now. I think we're doing good on time. This young man on the screen is Dr. Mark Peel. He's gonna kill me for putting up that picture, but Mark is an incredible physician, an incredible innovator. I think most of the people who use whole blood, or if you're using his device for sepsis in the field or just fluids in general, he came out with the LifeFlow, and I got pretty banged up on Twitter the other day when I said that we can give a unit of whole blood in 2 minutes. His ER doctors had no idea what I was talking about, so I said this is how we do it. But I wanted to bring Mark up here to talk about some of the publications that are coming out, some that he's a part of. So Mark, if you wouldn't mind coming up on the stage and giving us a quick update.
Yes, and I want to know where you got that picture.
Not going to tell you. Let's play. There you go. We're good. Yep.
Okay. All right. Thanks for inviting me. A quick disclosure, as Peter mentioned, I do have a conflict of interest in that some of the agencies I'm talking about here are using a device I helped invent for the delivery of blood. But I've had the privilege of being able to be involved in some of this research, and I wanted to share a bit of it. There's a lot more coming. These are just some early teasers, but this one came out of New Orleans and Tulane University, presented at ESO recently, and I'll just share some of the early experience from the New Orleans group, where they did a prospective cohort study, 2 years, evaluating their advanced resuscitative care bundle, which includes 2 of TXA, 2 of calcium, and 2 units of packed red blood cells. I know most people are using whole blood now. Tom might be able to address it if we have time. They had trouble getting the whole blood and actually have done quite well with red cells alone. They're giving blood to trauma patients with evidence of shock, systolic under 70 or systolic under 90 with a high heart rate. This study looked at only penetrating injury. Exclusion criteria were those with isolated head injury and pre-hospital arrest, and their primary outcome variable was seen versus ED shock index. So here are the pretty exciting results. And remember, this is not a comparison between a pre and post. I'll tell you about that in a minute. This is just a raw evaluation of the first 61 patients with penetrating trauma, with a median age of about 35. And 85% is their total mix of penetrating versus blunt in New Orleans. They have a lot of gun violence there, sadly. But 100% of the patients in this study had penetrating torso trauma. Scene times, you can see, were 8 minutes, transported 9.5 minutes, a total pre-hospital time of about 24 from call to hospital, and mortality of 12%, fascinatingly. Primary outcome variable was shock index change. So a really high shock index of 1.4. Dr. Pepe's and someone else, I can't remember who made this point, but patients, this probably underestimates the true shock index because folks who are pre-arrest are going to have paradoxically low heart rate, and their shock index will not be reflective of their physiology. So nevertheless, these patients had a high on-scene shock index, which was essentially normal by arrival to the ED, during which time, and note the transport times here, 9.5 minutes, the New Orleans paramedics were able to get in 2 units of packed cells. About 90% of patients got 2 units, 2 grams of TXA and 2 of calcium. Pre and post vital signs, you can see here, change pretty readily and nicely. And then the mortality of 12% is pretty remarkable. And if you'll also notice the line above it, very few patients in their advanced resuscitative care bundle, though critically ill, high shock index, got intubated. Meaning, I think what's happening is folks are getting resuscitated quickly in short transport times. Mental status is improving, and they are not then perceived to need an advanced airway. So saving a heroic and potentially deadly intervention in these patients is pretty cool. And this is all accomplished in a 5-mile radius on average and 9-minute scene time. I agree that this doesn't always apply in areas like Eric, we have 45-minute transports, or in Colorado, but this is certainly relevant in urban environments. And I thought several authors of this paper are now on the call, but I thought I'd just review what just came out, Peter, of your agency and Chief Coyle's, where Palm Beach County published their early experience, similar enrollment criteria, giving a unit of whole blood, mostly getting 1 unit, 2 grams of TXA, no calcium, And I think patients can get a second unit if they need it or that is available. And then you see the PEACH criteria below, and then their outcomes among patients who did not have a pre-hospital arrest. And this is important when you're looking at the data. Some studies exclude their arrest and some don't. And what we've seen in both agencies, and actually I believe in Broward as well, is that very few of the scene arrests ever survive. No matter what you do, they're not going to survive. So if you exclude those patients from the analysis, these mortality numbers are really, really fascinating and dramatic. And so there again, they've had about a 10% mortality on their admittedly lower number of patients, 10 patients who were not arrested at the scene. And they again have short transport times. What we're hoping to do is combine these two data sets, I hope, and compare disparate agencies with similar transport times, similar administration methods, but the differential of giving packed cells versus whole blood and calcium versus not, and warmed blood versus not. And interestingly, New Orleans is actually not warming their blood, still seeing great outcomes. It's pretty fascinating. And then lastly, Peter, I'll share that I believe we'll soon be publishing a case control study out of New Orleans looking at historical controls compared to a now larger data set of pre-hospital whole blood or packed cell patients, showing a fairly dramatic reduction in mortality from pre-implementation of blood. So pretty exciting data. Probably the first published study that will be published showing mortality reduction for whole blood or pre-hospital blood in civilian EMS that has yet been published. So pretty exciting stuff. I'm happy to take any questions on it, Peter, but I'll stop in the interest of time.
Awesome. And just for the update, this paper was published after 20 patients, after 56. Like Charlie mentioned, we have 35 non-arrests, 31 survived. That's an 89%. So we're still on track, just like the other agencies are doing. So, this is important. And that's why I'm going to have Dr. Tatum come on shortly, because without the data, we're nowhere. So that's very important. So thanks, Mark. And one of my first, just a little funny story. One of the first times that I ever met Mark is on YouTube, because he was the crazy doctor who drilled himself with an IO. And I think, how many hundreds of thousands of views did you get on that, Mark? That was pretty good.
It's over 500 now, at least. So yeah,
Okay.
just Google doctor drills his own leg and you'll see it somewhere.
All right, excellent. Thanks, Mark, for the update. I'm going to bring in real quick Dr. Ken Shepke he's the Deputy Secretary of Health for the state of Florida, and he's done some incredible stuff for us in the state of Florida because of his background in EM and, of course, a big EMS medical director. So, Dr. Shepke, you on the call?
Well, thanks very much, Peter. I appreciate the time and the excellent talks already from all these experts. So first, I know we're talking about whole blood, and one of the things that's great about EMS is how we're able to stand on each other's shoulders and really borrow from each other. Or I'd like to say, we have a very large R&D budget, our rip off and duplicate budget. And we do that constantly, whether it's from Dr. Wakeler, Holcomb, certainly Dr. Roach, and others that have really been key in this. I'll tell you, at the state level, I think there's more and more realization of the critical role EMS plays in the healthcare system. And if you just look historically, there's a lot of things that we consider to be very time sensitive, so much so that the hospitals measure door to X, whatever the arrival to the ER time to X happens to be. And one of the things I think we as EMS subject matter experts are starting to realize is that if we have something that is so critical that it's really important to do it really early on in the ER phase of care, that means it's even more important for us to do it in the pre-hospital phase of care. And study after study has borne this out, that those time critical things, while it's really important and you get better results when you do it early in the ER, we get even better results when we do it pre-hospital. And the blood is certainly one of the things that fall into that. And one of the things from a physiological standpoint that I just want to point out to folks is the common sense approach to this. I mean, for years, we've been treating people with saline to make their blood pressure look good. And we're talking about shock index, and that certainly makes their vital signs look better. But it's really not just about vital signs. I just want to quickly just talk about physiology here. That's common sense physiology. It turns out that when you leak out red stuff, you should replace it with red stuff, not clear stuff. And that's what the science is showing. But more importantly, many of the patients that we were able to resuscitate in the past, even with fluids, and we got their blood pressure better, they would go on to die later from multi-organ system failure. So they might arrive to the hospital, but at the cellular level, The reason why I think these pre-hospital whole blood programs are so valuable is if a cell gets hypoxic due to severe shock, hemorrhagic shock, it may survive to make it to the hospital where they'll start to resuscitate. But once you start the shock cascade or the cellular death cascade, that organ's going to die. Those bunch of cells are going to die, and that patient might live in the ER, but will end up dying from multi-organ system failure. And I think that's one of the unsung benefits of pre-hospital whole blood is we're not seeing that in these cases. These patients, not only resuscitating them early, we're not seeing the late group of deaths that we typically see in multi-system organ failure that we see from trauma. So that's a key thing. And again, just what from an EMS standpoint and where the state gets involved, we're already copying best practices here in Florida and spreading it around the state. So our latest program is Resuscitate Florida. And so for the EMS chiefs and EMS medical directors are on the call right now, what we're doing at Resuscitate Florida is we got a $15 million grant to put the best practices for medical cardiac arrest around the state to make us, the highest survival rate for out-of-hospital cardiac arrest. And if you're interested in getting in that, it's equipment, it's training, it's all the best practices stuff from dispatcher life support, mechanical CPR, the ELOGuard, the whole bundle of care that you've heard some of the experts on this call talk about. I know it's a different topic here. Get in touch with Chief DiBernardo if you're interested in that. But I definitely do want to thank this group and Peter certainly for spreading the word on this, because I think pre-hospital whole blood is another area where we in Florida should probably take some of these best practices. And while we're doing Resuscitate Florida as best practice for medical cardiac arrest, we should probably be looking at a whole blood program, again, for pre-hospital providers here in our state and take those best practices and help roll that out. So if there's interest in that, please contact my office and we'll get into it. Thanks, Peter. I'll put it back to you.
Awesome. Great update. And definitely we're going to be moving in that direction. So thank you for that. And it's always great to have people at the state level. I mean, I never realized it until Ken got up there, how important it is to have that type of leadership up there. So we're very grateful for that. Now I'm going to bring in someone who, again, I've never met her in real life, but I sent her so many emails trying to connect the dots. So pay close attention to Dr. Danielle Tatum, because they're doing some big things. Think CARES registry, but for whole blood. They are, don't go and recreate your own data thing. Just talk to Danielle. So Dr. Tatum, if you can come on, talk to us about the 2-lane registry for those who don't know about it. A lot of people are texting me, how do I get involved in that? So if you can give us an update, we'd appreciate it.
And I can drop my email in the chat too. So if you do want to get connected or find out more about it, just email me directly and I'll send you some information. And if you want to take it a step farther and get involved, I'll have this awesome med student who's helping me kind of keep the regulatory pieces all in order for everyone who wants to be onboarded. And I will clarify, we're not just limiting this to whole blood. If you have a whole blood program, that's awesome. As we mentioned in New Orleans, we don't. We're giving packed cells. But if you give nothing at all, if you're in the process of starting a program or you're in early talks, we're equal opportunity. This is a very pragmatic design, prospective, observational registry that we're building because we want those comparator groups. We really want this registry to be robust where we can answer, lots of questions. And I've just been jotting, as thoughts happen. I mentioned urban versus rural. Rural is going to be its own subset. We'll need to look at those times and the outcomes in that patient population because, they're different, right? Penetrating versus blunt. We have a very high penetrating population here in New Orleans that doesn't necessarily, I know other states, don't necessarily have our same level of gun violence, which good for you. Ascertaining what's a non-survivable injury. We're all excluding our traumatic shock, those who cardiac arrest, pre-hospital or, probably maybe almost dead when the blood starts. So, trying to figure out who is salvageable, who's not. But so from the New Orleans in right now, we have, as of Friday, and Tom can step in if we've added more, we had 179 pre-hospital blood administrations. So Mark's poster that he just presented was a little bit while back. We only had 61. So, things are rolling pretty good here. We have.
Yeah, we're up 183 right now. So.
Okay. Yeah. We, like I said, it's very, very vast majority of it is gun violence and again, no shortage here. So, our administrations tick up pretty quickly. And we have probably, I looked at my list, I need to update and add 1 or 2 more centers, about a dozen centers in the process right now with their data use agreements. That's step 1 to come on board. We'll have to execute that between our institutions, IRB, and all these things that can take some time and are generally the rate limiting steps. But once you get on board, you're free to enter your data. I talked with the center earlier. We're not looking for any target numbers. Patient volumes differ in each place. Like I said, it's very pragmatic. So whatever your program is currently, we welcome you because I think there are a lot of questions we can answer. We share this data. If you participate, it doesn't belong to Tulane. We're collaborators, not dictators. So we're happy to work collaboratively and to share. The more answers we can get out of this database, if we do this well, I think we're only going to serve our patient populations better. Like I said, bureaucratic steps are getting a data use agreement. You'll need your institutional IRB, or if you're a pre-hospital provider and you have, if you're part of an academic center or hospital, maybe their IRB. And then we'll work with you to give you a Tulane email address because you'll need that to get into the REDCap database. And Tulane also requires you do some REDCap training. It's not that horrible. Pour your favorite drink or whatnot and just get through it. And so we're hoping that, as we continue to have these calls and as word of mouth spreads and as programs continue to grow, we're onboarding more and more. Again, I can't emphasize it enough. It's really, I like the moniker at the Tulane Registry, but really it's more for everyone in terms of if you contribute, you can certainly get things out of it too. I don't know, let's see what we have going forward. So Mark alluded to our historical controls who are hemorrhagically unstable, hypertensive in the field, comparing them now to those who have gotten the blood, calcium, and TXA bundle. And yes, we are presenting that as a podium presentation in September in Anaheim at the American Association for the Surgery of Trauma meeting. That manuscript is due soon, I think August 1st. Mark's actually been quite involved with that and is doing some edits on it probably now or after this. And then we're also looking at our outcomes in our PEDS population. We're defining that as anyone under 18 because we have a lot of teenagers who engage in gun violence. And I think that's probably an understudied patient population. So come on board. We have a lot of opportunities for a lot of collaborations. And if you guys have any questions or, like I said, want more information, I'm going to drop my email in the chat now and I will be your point person.
That's for you. I put your email in there for
good. Yeah,
absolutely.
Nice. Thank you.
Thank you. This is wonderful. I mean, it's nice that this is all that you guys kind of had this started as this thing is starting to grow, and I'm hoping all the data ends up in your neck of the woods there, so we can make something of it moving along. So, and every webinar, I'd love to bring you back in so you can continue to update us on how that's all going.
Yeah, and I'm happy to say it's been made easier. We do have a great relationship with New Orleans EMS. Tom and his team have been just awesome. We got great collaborations, from Mark and his side. So it's a really great group effort. So a little kumbaya, I know, but come on board. It's all good. Yeah.
All right, Mardi Gras in Tulane. We can celebrate the successes.
Yeah, and it's not hot during Mardi Gras, so I recommend it.
And hopefully not get shot. Okay.
Well, good luck.
All right. Well, thank you, Danielle. We appreciate that. Now we're going to bring in John. Dr. John Kramer is the immediate past director of the Office of EMS at NHTSA, and he is initiating a big federal movement. So although he tried to, think about retiring, etc., that ain't happening. So John, thank you so much for coming on. And if you can give us an update on the amazing stuff you're working on at the federal level.
Thanks, Peter. And I just need to clarify one thing, and this comes from the federal bureaucratic perspective. This is not a federal initiative. This is a national initiative. When we talk about federal initiatives, folks equate that with sponsorship and support and being run by the federal government. This is not. This is what we are doing is forming a National Blood Transfusion Initiative Coalition. And this really is building on, but not replacing what many of you all have been talking about with the Florida coalition. There's a coalition, as was mentioned, in Colorado, Texas, North Carolina, and things like that. Several months ago, a group of folks got together and started talking about these blood programs, focusing primarily on the reimbursement issue, because as you all are aware, nobody's getting reimbursed for that. It became very quickly apparent, although reimbursement is an extremely important issue, there are other issues like scope of practice, as was alluded to in Colorado. They've come up with a very novel way of addressing that. Texas doesn't have to worry about it because they can do things. You've addressed them in Florida. So reimbursement is an issue, scope of practice is an issue, outreach and communications is an issue. So we have, and Randy and Eric have been integral in these early discussions, as have been a number of players on the blood supplier side and other folks. Came to the realization that although it's important to work on these things, it would be helpful to bring everybody kind of together to share information, learn about experiences, come up with common messages to the extent that we can. When we do start talking about scope of practice issues, it will be very state to state dependent. When we start talking about reimbursement issues, we need to be consistent and have a common approach to that. So we're forming this coalition. Invitations have been sent out recently to the national EMS organizations, to the state coalitions that participate, to the blood programs, anybody and everybody that is potentially interested. We are hoping at some point in time through sponsorship, and this is why one of the reasons I had to clarify that it's a national effort, not a federal issue. Through sponsorship, we're hoping to be able to engage some Washington folks, read that to mean lobbyists, that are able to work with federal agencies and work with Congress to try and present this issue and develop an appropriate mechanism for reimbursement so that agencies aren't eating the cost of all of these things. So it is designed to be inclusive. We have reached out now to the players that we're aware of, Randy and Eric, on the database that they've been developing. You'll hear more about it. We're welcoming participation. It, again, is not to replace anything that the Florida Coalition is doing or any other agencies, but to try and bring folks together to, on a national level, hopefully improve communications, improve information sharing and things like that. So anybody has any further questions? And this is not a me project. I'm helping to coordinate and facilitate it, but whoops, sorry about that. But we have a steering committee that has been formed. We've identified 4 pillars of activities: reimbursement, scope of practice, education and outreach, and strategic planning. More to follow, but I appreciate the opportunity to at least bring it up. And just please don't, we are engaging federal agencies from an education and an interaction perspective, but this is not a federal initiative. This is a national initiative, sort of a groundswell type thing. Thank you. If folks have questions, please give me a chat or a call, and I'll put my email in the put my email address in as well.
Thanks, Dr. Kramer. I appreciate that. And thank you for the clarification. I don't want to put you in a corner there. Just you're in my opinion, you're like the person who knows how to interact from the federal side of things. And we definitely are greatly appreciative of the movement that you're starting with the team. So thank you for that. And let's see, is Dr. Winkler on the call? I wanted to save him for last because, you know, I figured like, let's get him on the call, but I don't see him on. CJ, you there? All right. If not, let's end with this. And Dr. Shepke just reminded me that we should talk a little bit about what's going to happen in the future, right? And he says that if if you look at what's happening in the war in Ukraine, how they can take a drone and drop it on a target, why can't we drop the life-saving blood onto a target? So this is definitely the future. I also have coming onto the Florida EMS webinar, which I do every Tuesday. You all are invited. There's a company out of Orlando who is going to be making blood, real blood from cells. So imagine having this kind of ability to manufacture real blood so that we don't have to go from real people. So it's still early, but they have some DoD grants to actually get that done. Exciting stuff. So I know that we're about 9 minutes over. I'm surprised we're only 9 minutes over. So here is the QR code for anyone who wants everything that's in our folder, all the PowerPoints. This video will be available on YouTube very shortly. And how about we just spend a couple of minutes here and we open it up for to the group